Hello, everyone. Thank you for joining our webinar today with Dr. Dorian Lamis on the topic of assessing and treating suicidal patients with bipolar disorder. There will be a 10-minute question and answer session at the end of the talk, so get your questions ready and drop them in the chat box at any time. Dr. Lamis is a board-certified licensed clinical psychologist and associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. He provides direct clinical and administrative services in the Grady Memorial Hospital Behavioral Health Outpatient Clinic with patients diagnosed with serious mental illness and/or are at risk for suicide. Dr. Lamis's research focuses on mood disorders, substance use, and suicidal behaviors in a variety of populations, and he has published over 150 peer-reviewed articles and book chapters on these topics. Additionally, he is the Director of Education and Training at the Injury Prevention Research Center at Emory and the Associate Director of the Postdoctoral Residency Program in Health Service Psychology. With that being said, welcome, Dr. Lamis. It is a pleasure to have you.
Thank you. I really appreciate the invitation to speak to you today. I'll be talking about assessing and treating suicidal patients diagnosed with bipolar disorder. So here are my financial and non-financial disclosures. So today's lecture will cover bipolar disorder and suicide risk, a general overview. And then I'll discuss suicide risk assessment in patients diagnosed with bipolar disorder. Then I'll provide some information on the cutting edge treatment and intervention approaches. And then provide some results from findings in the bipolar clinic and research program at Grady Hospital here in Atlanta, Georgia. And then finally, some conclusions and future directions. So bipolar disorder is a major public health concern. The prevalence of the diagnosis is about 1 to 3% worldwide. It's the sixth leading cause of disability in the world, and about 4.4% of adults living in the United States experience bipolar disorder in their lifetime. About 33% of patients diagnosed with bipolar disorder fail to comply with treatment. And this treatment non-adherence often results in hospitalization and/or suicide. And suicidal behavior is also a major public health concern. It is now the 11th leading cause of death in the United States. Historically, it's been the 10th leading cause of death, but in the last few years, COVID has jumped into the top 10, pushing suicide to the 11th. But regardless, it's still a major public health concern in the United States and worldwide. The suicide rate in the United States is 14.1 per 100,000, and about 48,000 people died by suicide in 2021. And the CDC recently released data, provisional data in 2022, showing that the rate has actually increased some, with the number of deaths approaching 50,000 per year in 2022. Each day, about 130 people in the United States die by suicide, and 1.7 million attempt suicide each year. And it's estimated that about 12.3 million people have suicidal thoughts. And these estimates of suicidal thoughts and attempts are most likely underestimates, given that people often don't disclose their suicidal thoughts, and suicide attempts are not always coded in the accurate manner. With regards to suicidal ideation and behavior in bipolar disorder confers one of the highest risks for suicide among all DSM-5 diagnoses. The suicide rate in bipolar disorder 1 and 2 is approximately 25 to 30 times higher than that of the general population. About 50% of people diagnosed with bipolar disorder experience lifetime suicidal ideation, and about 30% attempt suicide in their lifetime. And then lastly, around 10 to 15% of individuals diagnosed with bipolar disorder die by suicide. So as you can see, suicidal ideation and behavior and death is highly prevalent among individuals diagnosed with bipolar disorder. So this is the typical conceptualization of bipolar disorder, with discrete phases of depressive and manic symptoms in bipolar 1 and depressive and hypomanic symptoms in bipolar 2. And at the bottom of this graph, the unipolar depression is relatively constant in the depressive phase. However, in reality, it is not that clear cut, and bipolar patients commonly experience mixed episodes, which include predominantly manic episodes with at least 3 symptoms of depression, or predominantly depressive episodes with 3 manic or hypomanic symptoms. So for this reason, bipolar disorder is notoriously difficult to diagnose, especially in patients who present during a depressive episode and in those with no clear history of mania or hypomania. And another reason for this difficulty in diagnosing bipolar disorder is that the prevalence of depressive symptoms is higher than that of hypomanic and manic symptoms during the course of the illness, and it often starts with a depressive episode. And further complicating the inaccurate diagnosis of bipolar disorder is that people diagnosed often spend much of their lives depressed. In all of these studies, some of which followed patients for 13 years and others which used self-ratings over a 1-year period, bipolar 1 and 2 disorder patients were found to be symptomatic about half of the time, with the majority of their time being spent in depressive states. So on these graphs and the pie charts, the no symptoms is pink, and then the depressive symptoms is depicted in yellow. So as you can see, the manic and hypomanic symptoms are not often prevalent, whereas either no symptoms or depressive symptoms really are the main episodes that bipolar patients experience. So you can see how and why it is really difficult to accurately diagnose bipolar disorder. In fact, some studies have shown that close to 70% of bipolar disorder patients may be misdiagnosed, and they most commonly receive an inaccurate diagnosis of depression. And this is followed by anxiety disorder, schizophrenia, or borderline personality disorder. There's also a significant delay in the accurate diagnosis of bipolar disorder following an initial diagnosis of major depressive disorder. So this schematic depicts the delay with the width of each bar here along the x-axis, representing the number of patients in that group. So here there was a mean delay of 8.74 years to an accurate bipolar diagnosis. So it takes on average about 9 years for a person with bipolar disorder to be accurately diagnosed. So in this study of 320 bipolar outpatients, the researchers looked at the relation between the duration of untreated illness and suicide attempts. What they did was divide the patients into 2 groups. The graph on the left shows the duration of untreated illness less than 2 years and more than 2 years. And the graph on the right compares the duration of untreated illness less than 6 years versus more than 6 years. So in both of these analyses, the researchers found that the patients with a longer duration of untreated illness had a higher frequency of suicide attempts and a higher number a higher frequency of attempters and a higher number of attempts. And so this study really highlights the importance of not only accurately diagnosing patients with bipolar disorder, but also treating them as soon as possible, as the risk for suicide increases while they continue to go untreated. In this study of over 6,000 adult patients in a psychiatric center, suicide risk was found to be the highest among bipolar patients who experience prominent psychotic or mixed features in at least one episode. Patients diagnosed with bipolar type 1 had a higher risk of suicide compared to bipolar type 2. However, the difference in suicide risk between bipolar 1 and 2 is a somewhat controversial issue. Some studies have reported a higher rate of suicide in bipolar 2, and others have reported a higher rate in bipolar 1, whereas some studies have found no difference between the two. So the differences in suicidal behavior between bipolar 1 and bipolar 2 are likely attributed to the amount of time spent in episodes that are high risk, namely the depressive episodes and mixed states. In this study of suicide attempts during various phases of bipolar disorder in psychiatric and outpatients, the incidence of attempts was 37 times higher during depressed mixed and combined mixed states, and about 18 times higher during major depressive phases compared to the other phases. So these findings suggest that the fast and effective management of mixed and depressive phases of bipolar disorder, regardless of 1 or 2, may be crucial in reducing suicide attempts. So similarly, in a study of 290 bipolar 1 and 2 patients, more mixed episodes and being female predicted suicide attempts, whereas predominantly depressed episodes and more depressed mood and mixed episodes predicted suicidal ideation. So again, highlighting that mixed episodes and depressed episodes in the course of the illnesses are really the high risk times for patients diagnosed with bipolar disorder. In this prospective study following over 400 patients for a mean time period of 18 years, individuals with a history of mixed states were at higher risk for suicidal behavior than individuals with no history of mixed states, largely due to more time spent depressed. So we know that in general, the highest risk period for suicide across all diagnoses is immediately following discharge from psychiatric care. So in this study, specifically in 35,000 bipolar patients discharged from a psychiatric inpatient unit, the risk of suicide following discharge was by far the highest for bipolar patients hospitalized for depression, which was followed by mixed episodes. The suicide risk following discharge was lower and relatively stable for patients hospitalized due to mania. So when patients are discharged following mixed episodes or depressed episodes in bipolar disorder, that is when they're at the highest risk for suicide. So with regards to healthcare contacts in the year before suicide death, this study in over 6,000 individuals who died by suicide in health systems across 8 states, 83 of them received health care in the year prior to their death, and 45% of them had a mental health care visit during the year prior to their death. So the take-home message here from this study is that there is an opportunity to identify, diagnose, and assess high-risk patients in medical and mental health settings in order to treat them and ultimately prevent suicide. Okay, so now I hope you understand the relation between bipolar disorder and suicide risk. Now I'm going to talk about suicide risk assessment and specifically in bipolar patients. So first, it's really important to have a strong theoretical framework when conceptualizing, assessing, and treating suicide. The neurocognitive model of suicide and bipolar disorder was recently developed by Jed Malhi. He synthesized all available information about suicide with an emphasis on clinically relevant and diagnosis-specific evidence. So what he did was incorporate aspects from several well-known suicide theories, including the diathesis stress model of suicidal behavior, the interpersonal psychological theory of suicide, the integrated motivational volitional model of suicide, and the three-step model of suicide. So here in the neurocognitive model of suicide and bipolar disorder, he proposes there are 8 components on the pathway to suicide. They're distal risk factors, proximal risk factors, current state, appraisal, defeat and entrapment, ideation, intent, and attempt, with many identified risk and protective factors also incorporated and targets of intervention included. So this framework should really be helpful in identifying these targets of suicide prevention interventions for patients diagnosed with bipolar disorder. So for a suicide risk assessment, you really want to assess suicide at the earliest possible opportunity with a direct inquiry about their suicide risk. You want to ask about the nature, the extent, the duration of suicidal ideation, any previous attempts, the lethality of the attempts, if they have a current plan, and what is their access to means, particularly lethal means. You also want to do a mental status exam, paying particular attention to mood and psychosis, asking about a history of medication and treatment adherence, as well as monitoring change in clinical status and new symptoms. In addition to really assessing risk and protective factors for suicide, specifically in patients diagnosed with bipolar disorder. So some of these risk factors for suicide and bipolar disorder, these are, many of these are across all diagnoses and populations and samples, but some of these are really more specific to bipolar disorder patients. So if a person with bipolar disorder has a first-degree family history of suicide, they're at a much higher risk. For example, mother, father, siblings. So suicide runs in families, much like bipolar disorder does. Male gender, so we know that males die by suicide at a higher frequency than females, but females attempt suicide more than males, which is called the gender paradox of suicide. There's also a genetic vulnerability. Again, suicide runs in families. The younger age and onset of the disorder increases risk for suicide in subsequent years of life. Childhood physical, emotional, and sexual abuse is a risk factor for suicide, particularly sexual abuse. Predominantly current depressive or mixed episodes, as I mentioned earlier. We know that prior suicide attempt is the strongest predictor of subsequent attempts for death, in addition to prior or previous suicidal ideation. Comorbid anxiety, alcohol, substance abuse problems increases the risk for suicide in bipolar patients. Impulsivity and aggression also increases risk. Living alone, unemployment, financial issues, or really some acute stressors, environmental stressors in lives of individuals diagnosed with bipolar disorder increases suicide risk. Availability of lethal means, you always want to assess this. The more access they have to lethal means, particularly firearms, the higher risk they'll have of suicide death. Non-compliant and lack of treatment or wrong treatment can increase risk. And then, as I mentioned from that previous study, recent discharge from a hospital unit or psychiatric inpatient unit is a risk factor. In terms of protective factors for suicide and bipolar disorder, so having that family and social support or connectedness, the CDC has reported that social connectedness is the strongest risk factor for suicide and across all samples and populations. So the more family or social supported connectedness a patient feels, they will be less likely to have suicidal thoughts or attempt suicide. Having adaptive coping strategies, which can be taught through therapy and psychosocial interventions. Having a meaning and purpose in life. So if a patient wakes up and they really feel like they have meaning and purpose, that's going to serve as a protective factor for suicide. Often religious beliefs or involvement can be protective. If an individual has children, especially children living in the home, that could be a protective factor. Having a positive therapeutic alliance with a psychologist, a psychiatrist, or another mental health professional. Treatment and treatment response. So really finding the best treatment, whether that's pharmacological or psychosocial, can serve as protective factors. And adherence to pharmacotherapy and psychotherapy. So not just being prescribed medication or starting psychotherapy, but really adhering to the treatment regimen and continuing it as prescribed. And then again, this is a common theme, this reducing access to lethal means serve as a protective factor for suicide. So there currently are no validated suicide risk assessment tools specifically for individuals diagnosed with bipolar disorder. The Columbia Suicide Severity Rating Scale is thought of by some to be the gold standard in suicide risk assessment. And it's a semi-structured clinical interview assessing recent and, for example, 1 month and lifetime suicidal ideation and behaviors, including attempts. So this is really used to identify people who are at risk and can be used across all diagnoses and individuals. The suicide status form is used by the Collaborative Management and Assessment of Suicidality Treatment Approach, which I'll discuss a little later in the presentation. The SSF4 is a measure of overall risk of suicide and also assesses for core constructs, including psychological pain, stress, agitation, hopelessness, and self-hate. The Oxford Mental Illness and Suicide Tool is a brief, structured, web-based risk assessment tool to determine suicide risk in patients with severe mental illness, particularly schizophrenia spectrum disorders, but also bipolar spectrum disorders. And there have been some promising results on the external validation of this tool. One such study came out a few months ago looking at patients in Finland and showing that the tool has some external validity, but more research is really needed on the psychometric characteristics and the validity and reliability of this measure. And lastly here, the modular assessment of risk and imminent suicide. It's a multi-informant measure utilizing patient and clinician components that together assess explicit and indirect dimensions of suicidality, as well as acute and chronic risk factors. So really the most effective approach for determining a patient's risk for suicide is through a comprehensive clinical assessment, establishing potential risk and protective factors, using an evidence-based instrument for directly inquiring inquiring into current and past suicidal ideation and behavior, as well as, again, assessing for access to lethal means. All right, so moving on to treatment and intervention approaches. So lithium continues to be the first line of pharmacological treatment for bipolar disorder. Here, in an 8-year prospective study of over 5,000 bipolar patients, lithium reduced the rate of suicide attempts and deaths by 14%. And for valproate, there was no protective effect for suicide found. It was concluded here that 12% of suicide-related events could have been avoided if bipolar patients had taken lithium during the entire follow-up. So although there is evidence that lithium may decrease suicidal ideation and attempts in bipolar disorder, it is not currently FDA approved specifically for suicide. So in a more recent study, this 2022 randomized clinical trial, the researchers found that the addition of lithium to usual Veterans Affairs mental health care did not reduce the incidence of suicide-related events in veterans with major depression or bipolar disorder who experienced a recent suicide attempt. So there were 437 men and 82 women, and they gave 255 of the patients lithium, and 264 received a placebo, and they followed the patients. And what they concluded was that simply adding lithium to existing medication regimens is unlikely to be effective for preventing a broad range of suicide-related events in patients who are actively being treated for mood disorders. So after this study was published, a few months later in an editorial commenting on the results, Baldessarini and Tondo proposed instead that the findings, quote, cannot be taken as evidence that lithium lacks anti-suicidal effects due to numerous limitations in the study. And the first of these limitations was that most patients had non-bipolar depression. So only 15% of patients in the study had either bipolar 1 or bipolar 2 disorder. And additionally, the lithium levels that was administered was low overall, as well as there was a large dropout rate of 52%. Many of these patients dropping out early on in the study. So as you can see here, there's some conflicting evidence on the anti-suicidal effects of lithium. So much more research and clinical trials are needed on these effects, particularly in patients diagnosed with bipolar disorder. So as you probably heard in the news or are seeing, ketamine has garnered recent attention as a novel pharmacological treatment for both bipolar disorder and suicidality. So in this particular prospective double-blind randomized placebo-controlled clinical trial, participants included of 156 patients admitted to the hospital for suicidal ideation for either bipolar disorder, major depressive disorder, or other disorders, excluding psychotic disorders or patients with a recent or past month substance dependence. So the patients here were randomized to either placebo or ketamine, and the intervention was 2 40-minute intravenous infusions of ketamine or placebo administered at baseline and then 24 hours. And on the left, you can see on day 3 or 72 hours since infusion, the results indicated that 63% of patients in the ketamine arm and versus 31.6% of patients in the placebo arm had reached full remission of suicidal thoughts. On the right graph, between day 4 and 6, the ketamine arm continued to have a better full suicidal remission than the placebo arm. However, at week 6, there was not a significant difference, which may be due to reduced suicidality of the placebo group over time. So moreover, in the study, they found that there was a moderating effect by primary mental disorders. So specifically, a stronger effect of ketamine versus placebo was found for suicidal ideation in patients diagnosed with bipolar disorder versus major depressive disorders and other disorder groups. So although there are many randomized controlled trials on ketamine and depressive disorder, I was really only able to find a handful of RCTs that included patients diagnosed with bipolar disorder looking at suicide outcomes. One of the studies was a double-blind randomized controlled trial among bipolar patients maintained on therapeutic levels of lithium or valproate and received single intravenous infusions of either ketamine or placebo. So within 40 minutes, suicidal ideation significantly decreased in bipolar patients receiving ketamine compared to placebo. And the reduction remained significant through day 3. So these results suggest that ketamine may have rapid anti-suicidal effects, but are not long-lasting for most patients. And lastly, in this small randomized clinical trial looking at ketamine versus midazolam, bipolar patients with clinically significant suicidal thoughts were either given ketamine or midazolam. And the figure on the left depicts the change in suicidal ideation severity from baseline to 24 hours following infusion. So as you can see, the scores on the Beck scale for suicidal ideation were almost 6 points lower after ketamine than after midazolam at 24 hours. And the figure on the right shows suicidal ideation during follow-up treatment in the bipolar patient randomized to ketamine. Suicidal ideation was lower than baseline at 230 minutes, at day 1, at week 1, and at week 6. So these findings are promising, but again, more clinical trials on ketamine's anti-suicidal effects of bipolar patients are needed. I also want to mention another potential medication, which is clozapine. And clozapine is the only medication with an indication by the FDA for reduction of the risk of recurrent suicidal behavior in schizophrenia and schizoaffective disorders. It's indicated in schizophrenia spectrum disorders, not bipolar disorder. So more research is needed in this area. All right, so the limits of pharmacotherapy. So even with good compliance, relapse is common in patients diagnosed with bipolar disorder. So other treatment approaches are needed. So psychosocial treatments can help. They can modify stressors that can trigger episodes in suicidality. They can reduce acute symptoms. They can address psychological consequences of illness to self, family, and friends. And then psychosocial interventions may have direct biological treatment effects, for example, on sleep cycles. So why should we consider psychosocial treatments? They really introduce a more ambitious treatment paradigm. They increase its acceptance of the stress vulnerability model, the limits of pharmacological treatment, as I mentioned, and the non-adherence to taking medication. There's a medication refractoriness period and side effects which may happen, as well as the switch. So patients who have bipolar disorder who are first prescribed antidepressants because they're in a depressive episode, it may trigger mania, which could be a risk for suicide, and especially in that mixed state. And then the increased suicide risk and medication overdose concern with medications. So the psychosocial treatments I'm going to discuss today are psychoeducation, cognitive behavioral therapy, dialectical behavioral therapy, interpersonal and social rhythm therapy, family-focused therapy, and collaborative assessment and management of suicidality. Psychoeducation topics include the early recognition and signs of symptoms, an overview of course and impact of illness, importance of treatment adherence, the daily life management skills, dealing with families, relationships, and employers, identifying and managing suicide risk factors and triggers, and then reducing access to lethal means. So psychoeducation is not just providing information or giving a booklet or a website to your patients for self-help. It really is a manualized treatment and training, and provides patients with empowering tools, enhancing coping strategies, encouraging informed proactive behavior, and promoting self-care. So in this randomized controlled trial, group psychoeducation for bipolar disorder was compared to a non-structured group intervention during a 5-year follow-up. And at the 5-year follow-up, time to any recurrence of mood episode was longer for the psychoeducation group. The psychoeducation group also had fewer recurrences of any type, and they spent less time acutely ill or in the hospital compared to the control group. So this graph shows the total number of mood episodes experienced and broke it down by type of episode. So as you can see here, there are significantly less episodes in the psychoeducation group compared to the control group. In this controlled trial compared group psychoeducation and medication versus medication alone in bipolar disorder outpatients. Psychoeducation increased the time to depressive, manic, hypomanic, and mixed reoccurrences. So the survival curves here show the time to any reoccurrence for the treatment and control groups, which was significant. So psychoeducation also here reduced the number of recurrences and hospitalizations per patient. So group psychoeducation is a useful adjunctive treatment with maintenance pharmacotherapy to prevent recurrences of bipolar disorder episodes. And in this systematic review of psychoeducation versus treatment as usual in patients with bipolar disorder, overall psychoeducation was found to be effective in preventing relapse. In this graph, the number on the right are the odds ratios of not relapsing into any episode. So any value greater than 1 here favor psychoeducation compared to treatment as usual. So psychoeducation really should be considered in combination with pharmacotherapy. And here is the manual for psychoeducation for bipolar disorder. Moving on to cognitive behavioral therapy for bipolar disorder. The session contents here include an overview of bipolar disorder within a CBT framework. It includes cognitive and behavioral strategies for monitoring and preventing depression, cognitive behavioral strategies for identifying and preventing mania, coping with psychosocial stressors, and self-management, and self-monitoring for relapse prevention, again, all within a CBT framework. In this randomized controlled trial of bipolar 1 patients, a CBT group of 14 sessions was compared to treatment as usual. And the figure here depicts the survival analysis of 2 groups. 44% of the patients in the CBT group had relapse at month 12 versus 75% of the patients in the control group. For the patients in the CBT group, they also had less overall mood symptoms and higher social functioning than the treatment as usual group. This graph shows the days in mood disorders during a 12-month period. So the CBT group had fewer overall bipolar episodes and specific episodes in the patients in the treatment as usual group. In a more recent systematic review and meta-analysis of CBT for bipolar disorder, a total of 19 randomized controlled trials comprising approximately 14,000 patients were evaluated. And the meta-analysis revealed that CBT is effective in lowering the relapse rate reducing depression levels, improving mania severity, and increasing psychosocial functioning with mild to moderate effect sizes. So CBT should be considered as a therapy, especially adjunctive to medications in patients with bipolar disorder, given the positive effects found in post-treatment and follow-up. And here are the manuals for CBT, specifically for bipolar disorder, and the accompanying workbook. So there's also a cognitive behavioral therapy treatment specifically for suicide prevention. And the sessions here include orientations to the basics of CBT, case conceptualization, setting goals specific to suicidal ideation and behavior, a narrative timeline, and creating a chain analysis and developing coping skills, cognitive restructuring related to suicidality, developing a hope kit, a safety plan, and relapse prevention. So this treatment has been found to be effective in reducing suicide risk. In the Brown RCT on the left, 120 patients who attempted suicide and were admitted into a hospital emergency department within 48 hours of the attempt, and then were followed for 18 months. The survival curve showed that participants in the 10-session CBT for suicide prevention intervention had significantly lower suicide reattempt rate and were 50% less likely to reattempt suicide than patients in the usual care group. In the RCT on the right, an 8-session CBT for suicide prevention showed that both groups in the CBT group as well as the treatment as usual were, in the CBT group were significantly less likely to make a suicide attempt during follow-up as compared to patients in the treatment as usual group. And in this systematic review of CBT for suicide prevention, the majority of RCTs demonstrated an effect of reducing suicidal cognitions and behaviors compared to treatment as usual, suggesting that CBT for suicide prevention is a useful strategy to reduce suicide risk. And so health professionals really should be trained in CBT techniques focusing on suicide risk. Here are the manuals for CBT for suicide prevention. As most of y'all have probably heard, dialectical behavior therapy is a very promising and effective treatment for a variety of diagnoses. The components of DBT include individual therapy, weekly skills training group, phone coaching component, and a therapist consultation team. The skills include mindfulness, interpersonal effectiveness, emotion regulation, and distress tolerance. So again, DBT has been shown to be effective in a variety of diagnoses, but the most evidence is for patients diagnosed with borderline personality disorder. And DBT has also been effective in decreasing suicide risk. In the randomized controlled trial on the left, which evaluated 1 year of DBT compared to 1 year of community treatment by experts, and then followed patients for 1 year after the interventions, the results showed that the DBT group had half the rate of suicide attempts compared to the community treated by experts group. In addition, the DBT group required less hospitalizations for suicidal ideation and fewer emergency department visits. So 4 research studies to date have examined DBT in treating bipolar disorder, 2 of which are in adolescents. So for the GOLD study on the top right graph, conducted in an outpatient clinic, bipolar patients exhibited significant improvements from pre to post treatment in suicidal ideation and intent. And in the bottom right Goldstein RCT, improvements were found in depressive symptom severity, as well as suicidal ideation over 1 year among adolescents receiving DBT versus the psychosocial treatment as usual in bipolar adolescents. So obviously more randomized controlled trials and studies are needed to evaluate the efficacy and effectiveness of DBT in patients diagnosed with bipolar disorder. But from what the studies have shown, it is a effective treatment. Here are the DBT therapy manuals. So the one on the left was the original one for borderline personality disorder. And the one on the right is a DBT therapy skills workbook specifically for bipolar disorder. So interpersonal and social rhythm therapy was developed specifically for patients with bipolar disorder. The goals of this treatment is to stabilize routines, to retrain the body clock, to gain insight into the relations among mood, interpersonal events, and routines, ameliorate problems related to grief, role transitions, role disputes, and interpersonal problems, regulate sleep and social rhythms, and then prevent reoccurrence of episodes. So there's been several randomized controlled trials looking at this treatment. On the left, the percentage of individuals who made a suicide attempt and engaged in non-self-injury was reduced significantly from baseline to 3-year follow-up. And on the right is a 2021 meta-analysis. And the researchers found that interpersonal and social rhythm therapy was effective in improving overall functioning in patients with bipolar disorder. And in 5 of the 6 studies included, interpersonal and social rhythm therapy had a significant effect on improving mood symptoms compared to controls. But given that interpersonal and social rhythm therapy has demonstrated effectiveness in treating bipolar disorder and may also decrease suicidality, it should be considered as an evidence-based psychosocial treatment option. Here's the manual for interpersonal and social rhythm therapy. The family-focused treatment of bipolar disorder really begins with an assessment of the patient and family and the interpersonal relations between the two. And then there's an engagement phase. So when you engage immediate family members, there's a psychoeducation for the patient and the family member about bipolar disorder. There's a communication enhancement training and a problem-solving skills training. So in the randomized controlled trial here, bipolar patients were assigned to either family-focused treatment and pharmacotherapy or a less intensive crisis management intervention and pharmacotherapy. And results showed that bipolar patients in the family-focused treatment group had fewer relapses, greater reduction in mood disorder symptoms, and better medication adherence than patients undergoing the crisis management intervention. So here specifically looking at suicidal ideation and behavior in youth, they looked at 4 months of family-focused treatment or 4 months of enhanced care with pharmacotherapy as needed. And what they found was patients who received the family-focused treatment had lower levels of suicidal ideation at follow-up compared to youth who received the enhanced care. And they also had longer intervals without a suicide attempt or threatened attempt with clear suicidal intent. So if the family is willing to be involved in the patient's treatment, family-focused therapy is an excellent psychosocial intervention approach for bipolar disorder. Now here are the family-focused treatment manuals, well, the manual and the survival guide. So to summarize, in a 2021 systematic review and component network meta-analysis examining 4 outcomes, including illness recurrence, depressive and manic symptoms at 12 months, and acceptability of treatment in 39 randomized controlled trials of bipolar patients, it was concluded that pharmacotherapy in combination with manualized psychotherapy was associated with a more effective reduction in recurrences and stabilization in mood episodes than pharmacotherapy with treatment as usual. So in the figure here, the nodes denote treatments and the lines denote trials performing the corresponding treatment comparison. So the size of the node is proportional to the number of studies that included each corresponding treatment. And the thickness corresponds to the number of studies performing each comparison. So cognitive behavioral therapy, psychoeducation, interpersonal social rhythm therapy, and family therapy all had comparable outcomes. So really, healthcare systems should offer the combination of these evidence-based psychosocial interventions and pharmacotherapy to patients diagnosed with bipolar disorder. Okay, and so the collaborative assessment and management of suicidality is a therapeutic framework for suicide-specific assessment and treatment of a patient's suicide risk. It's a flexible approach that can be used across all theoretical orientations and disciplines for a wide range of suicidal patients in treatment settings. So the 4 pillars of CAMS is empathy, collaboration, honesty, and suicide focus. And the clinician and patient really engage in a highly interactive assessment process, and the patient is actively involved in the development of their own treatment plan. So here, there's been randomized controlled trials in support of CAMS. The 2021 meta-analysis found that there was a significantly lower suicidal ideation and general distress compared to alternative interventions. So CAMS really should be considered as an evidence-based treatment to reduce suicide risk in high-risk patients, including patients diagnosed with bipolar disorder. So David Jobs, who is the developer of CAMS, just put out his 3rd edition of the manual, came out last month. So I really encourage you to check that out and use this treatment modality. I also want to mention 2 important interventions that are integral in both CAMS and the CBT for suicide prevention. That's the safety plan intervention, which is a document or can be used in an app that supports and guides someone when they are experiencing suicidal thoughts and helps them avoid an intense crisis. And the second intervention is reducing access to lethal means. So, for example, counseling on access to lethal means or CALM is a good intervention to limit access. So before I continue, I want to bring your attention to this review study indicating that African Americans with bipolar disorder have higher rates of misdiagnosis and lower quality outcomes in comparison to non-African Americans with bipolar disorder. There were also disparities found in treatment regimens and research participation in both intervention and genetic studies. So for example, in this Sazerac study, both African American and Hispanic Americans were more likely to have antipsychotics prescribed compared to Caucasian Americans. And the Kilbourne study, lower there, African Americans were less likely to receive suitable outpatient care within 90 days of index bipolar diagnosis compared to white Americans. So we really need a concerted effort from the research community to increase the inclusion of diverse patients in studies in bipolar disorder to address these diagnostic and treatment disparities and improve care. So, which brings me to some of my studies that have been carried out at the Grady Bipolar Clinic and Research Program here in Atlanta. So the procedure, patients can present to our clinic from all over the hospital, but also all over Georgia. We identify potential participants, Then the research personnel introduce the study to the patients. We review risk and benefits. Interested individuals are given a 10-minute screen. We assess eligibility and collect demographic characteristics, and then we schedule the patients for an assessment. We screen the patients for inclusion in the study with the mood disorders questionnaire. They have to have 7 or more mania symptoms. We collect saliva samples from each patient, and they then complete 13 self-report measures and are given a $10 Starbucks card for participation. We also have a clinical program, which includes an 8-week closed program of psychoeducation and medication management, CBT, mindfulness-based stress reduction, and interpersonal social rhythm therapy. And we also administer measures following the program completion, and public transportation and parking is provided. So we've collected data on about over 200 patients. The mean age is about 40 years old, about 70% female, around 73% African American, close to 80% unemployed, 30% homeless, and 80% make less than $1,000 a month. So really an indigent population of predominantly African American patients. So in the first study, we found that existential well-being, defined as having a sense of purpose and meaning in life, was significantly correlated with childhood sexual abuse, depressive symptoms, suicidal ideation, and behavior. Whereas religious well-being, defined as a perception of relationship with God, was not associated with any of these variables on the left. So the results indicated that existential well-being mediated the association between childhood sexual abuse and suicidal ideation, whereas religious well-being did not. So these results suggest that having meaning and purpose in life may serve as a protective factor against suicidal ideation among individuals with bipolar disorder who have experienced childhood sexual abuse, whereas having a relationship or belief in God may not serve the same function. In this second study, we tested the possible interaction effects of the serotonin transporter link promoter region and drug use on suicidal behavior in bipolar patients. And what we found was that the short and long allele of the serotonin transporter gene polymorphism had the opposite effect on suicidal behavior based on the individual's drug use. So specifically, for those with less or no drug use, the short allele was the risk or vulnerability factor, whereas for individuals with a higher amount of drug use, the long allele was the risk factor for predicting suicidal behavior. And this suggests that the short allele may have a protective and adapting effect compared to the long allele in a chronically stressful environment due to increased consequences of drug use. We found similar results when looking at childhood emotional abuse, namely the long allele of the serotonin transporter gene was a risk factor for suicidal ideation and behavior following an experience of emotional abuse as a child. This result was somewhat unexpected, as the majority of research implicates a short allele as a risk factor for suicidal behavior. So we were curious as to why we found this. We then separated the sample into African American and non-African Americans and looked at the association between an allele type and suicidal behavior. What we found was that the long allele was associated with suicidal behavior in African Americans, while the short allele conferred risk for suicide in a non-African American sample. But given that most genetic research has been conducted in white samples, it is possible that there are racial differences in genetic vulnerabilities for suicide. So much more research is needed to investigate this difference. So the objective of study 3 here was to use latent class analysis to examine subtypes of bipolar disorder. So we found 5 classes, including a minimal symptom, a mania, a moderately depressed, a severely depressed, and a mixed depression mania subtypes. So those in the severely depressed and mixed mania groups reported significantly higher levels of suicidal ideation and behavior compared to the other groups. So these results are consistent with previous research indicating that depressed and mixed states of bipolar disorder confer the highest risk for suicide. In study 4, we found that impulsive aggression mediated the relation between childhood sexual or childhood abuse and suicidal behavior for the sexual and emotional abuse. However, this was not the case for physical abuse. So these findings suggest that bipolar patients who experience emotional and sexual abuse in childhood may be more impulsive and aggressive in adulthood, increasing their suicide risk. But being a victim of childhood physical abuse may not have the same effect on impulsive aggression or suicidal behaviors in bipolar patients. In this study, which was published a few months ago, we conducted a discriminant analysis, which included 6 independent variables, 3 different types of childhood abuse, interpersonal needs, including perceived burdensomeness, authority, belongingness, and psyche. And the results revealed that the model was able to correctly classify the suicidal ideation group membership in 75% of individuals in the study. And then lastly, we compared means of key variables on pre-intervention and post-intervention assessments. We found reductions in depressive symptoms, suicidal ideation, impulsive aggression at post-test, and improvements in overall quality of life, physical health, psychological health, and social relationships at pre versus post-test. So it's important to note here, this is not a randomized controlled trial, so we're limited in how we interpret these results, but nonetheless, bipolar patients who participated in our group intervention did report positive effects. I know I'm close to running out of time here, so I'll go quick here. In conclusion, bipolar disorder and suicidal behavior are both major public health concerns and strongly related. Accurately diagnosing bipolar disorder in a timely manner and intervening during periods of high risk will prevent suicide. You need to conduct a comprehensive suicide risk assessment, and a combination of pharmacotherapy and evidence-based psychosocial interventions is most effective for treating bipolar disorder, particularly bipolar patients who are at risk for suicide. So future directions include we need to conduct more randomized controlled trials with suicide outcomes in bipolar disorder patients, particularly African American patients or other minority patients. We need to improve risk assessment and clinical care for bipolar disorder patients. Combining interventions addressing both bipolar disorder and suicide is needed. And then we really need to develop and test treatments for suicidal bipolar patients. So with regards to improving clinical care for bipolar disorder patients, it really will be necessary to train providers in these evidence-based practices, especially those who see high-risk patients. And with that, I am finished. So thank you again for having me.
Dr. Lamis, thank you so much. That was wonderful and very insightful. And I want to let our audience know at this time we will be answering a couple questions, so please type them. We will get to as many as we can. One question I have is, what can be done to help reduce the risk of suicide for the patients who are recently discharged from care, since that seemed to be the highest risk?
So, I mean, I think there's several things. One is doing a warm handoff if possible, which means getting them into outpatient treatment following discharge as soon as possible, and continuing those contacts. There's an intervention called caring contacts, which is shown to be effective. Which essentially is following discharge, you reach out to the patient, and you're not necessarily going into detail, but you're just reaching out, asking them how they're doing, continuing that contact with them, but really having them get into outpatient treatment, whether that's pharmacotherapy or psychosocial interventions, but as well as having them ensuring that they're taking their medication as prescribed, so they don't experience another depressive or mixed or manic state following discharge.
Mm-hmm. So our next question is, what should a patient do if they're on their medication, but they still have flashbacks of manic episodes? Is there any forms of therapy that could be beneficial for them?
So if you're referring to flashbacks as like a PTSD symptom or a traumatic event, there's definitely psychosocial interventions that specifically target flashbacks, nightmares, and traumatic experiences. Some of the two main ones are prolonged exposure therapy and cognitive processing therapy, which again address traumatic events that could be triggering flashbacks. But there are definitely psychosocial interventions that specifically address those.
That's good to know. And so our final question is one of our audience members wants to know, when does bipolar disorder develop? Is it from birth or develop later?
That's a great question. So the average age of onset of bipolar disorder is about 25 years old. It can develop earlier in adolescence. It's very rare that like children are diagnosed with bipolar disorder, but opinion, it is a combination of nature versus nurture. So if you have a genetic predisposition to bipolar disorder, and then you have stressful experiences, whether that's childhood abuse or other things that may trigger in that interaction of this genetic predisposition with a stressful life experience could trigger the symptoms, but it's usually, the onset is about 25. You see it mainly come on around 20 to 25, but that doesn't mean that it's not possible to develop earlier on or later in life.
Well, I want to say that's all the time we have for questions. Dr. Lamis, I thank you so much. This has been a wonderful presentation. Shared a lot of valuable information with our audience. And I just want to ask if you have any closing comments before we wrap this up.
No, I really appreciate you all joining the webinar. And if you have any questions, please feel free to reach out, email me comments, or want any information on any of the slides I presented today. But again, thank you.
Would you mind sharing your email one more time with the audience?
Yep.
Great. So if you have any questions, you can jot that email down. And once again, thank you all so much for joining. This webinar will be uploaded onto the IBPF website under educational videos and will also be published on our YouTube channel. I hope everyone has a great day. Thank you so much. Thank you again, Dr. Lamis.
Thank you.